internal jugular vein. That's enough of that. So here again is just showing you our 5 branches. You see it from a little bit better view. You can't really see ascending pharyngeal from this view. But again, making sure that you know superior thyroid, lingual, facial, occipital. Superior laryngeal is a branch of superior thyroid, not a direct branch of external carotid. And you see it's going through the thyrohyoid membrane along with the internal laryngeal nerve. So here's the internal jugular vein out lateral to the carotid. And the thing about it as well, I know some people got confused and thought the thing that was labeled might have been the vagus nerve. The other thing to look for is, look at all these other branches coming in. I mean, the vagus nerve is basically a straight nerve coming down. You don't really see anything happening with it. This thing will have all these other kind of tributaries going into it. So another way to help you tell the vein from the nerve. Not on the test, but in the lab, I want you to notice about the facial vein. We saw the artery a minute. The artery actually kind of dives deep behind it. Look, see how it's coming from deep to the mandible? So typically it goes into the submandibular gland and then goes deep to the mandible and comes back out and up to go up to the face. The facial vein does not take that pathway. Remember, it's coming this direction. It goes straight across, superficial to the mandible. It doesn't dive deep. It doesn't go into the submandibular gland. So there's facial vein. The artery is cut off on this one, but it's would have mirrored this. It goes underneath and then back out.
Dr. Spears, I have a question. On the carotid sinus, is it located in the internal jugular vein or the internal carotid artery?
Did I say jugular vein? I apologize, Deeps. Obviously, it's inside the internal, sorry. It's inside the internal carotid artery. I say it wrong a second time. That's really good. Thank you for catching that. I obviously say stuff wrong at times. So you see when I'm up looking at this diagram and I'm talking vein when it's the artery sitting there. So yes, carotid sinus inside the internal carotid artery. Ah, yes. Hopefully that's the only big one I'll make. It won't be, probably. Okay. So for those of you who don't know, I was here part of the TMJ course today, so I'm still thinking TMJ. That's not really true, but I'm trying to come up with some lame excuse for speaking incorrectly. Okay. I'm not going to go through this again, but what it's showing you is, again, the vagus nerve and those branches you have to know. So here, kind of hidden behind the internal, how did I know this was the internal carotid artery? No branches. Thank you so much. All right, so there's the superior laryngeal nerve splitting into internal and external. Internal doing what? Going through the thyrohyoid membrane along with what? Superior laryngeal artery. I don't think I have to beat that anymore, do I? Everybody should know that now. And then here is the recurrent laryngeal nerve. On one side it loops around the subclavian, the other side it loops around the arch of the aorta. I'll talk more about that when we do root of the neck coming up soon. There should be a better picture in a minute, but here's the trachea. So right behind the trachea would be the esophagus. So there's a groove between the trachea and the esophagus called the tracheoesophageal groove. On these models, one of the ways that you find this nerve is to look in that tracheoesophageal groove, and the nerve you see there, recurrent laryngeal. Somewhat similar to what you would see on this. Here's trachea, esophagus you can't really see, but that nerve running between the two structures back there would be recurrent laryngeal. Should be one on each side. Hopefully you've seen, I don't think you got, phrenic is something that's more into play in the next exam, not this exam. Because phrenic we see in what's called root of the neck. It'll be we're going to use something is a big landmark to help you identify phrenic. Don't worry about phrenic here. Worry about phrenic inside the thoracic cavity, because we haven't really talked about this region yet so much. Let's see. So a couple things I'll point out looking at this. So I'm going to get rid of the label. So when you see ansa cervicalis, you always want to take, like this aspect, follow it back up, and it should lead you right to the hypoglossal nerve. All right, so that makes this the superior root. The inferior root comes up and just kind of disappears. It has no connection to the hypoglossal nerve. So if you see that connection, be sure to call this superior root. Call the one more posterior the inferior root. Here's the hypoglossal nerve. Oh, look, there's an artery kind of wrapping around, giving a nice little hug to the hypoglossal nerve. What artery is this? Going in a posterior direction to the occipital bone? Occipital. And then, if you see where the superior root kind of comes off of hypoglossal, follow it along, and then a little more anteriorly, there comes C1. There's a C1 nerve going to thyroid. Okay. So we talked about this, how it's formed. All right, so let's talk a little bit about these muscles really quickly. So the infrahyoid muscles we mentioned all were innervated by ansa cervicalis except for one, thyrohyoid C1. So all of the infrahyoid muscles receive innervation from the cervical plexus. The suprahyoid muscles are not innervated by the cervical plexus. They're innervated by two cranial nerves. Either 7 facial nerve for stylohyoid, posterior digastric, or V3, and specifically you need to know nerve to mylohyoid. So somebody asked me a good question of the day because the notes show nerve to mylohyoid in parentheses V3. So some people got the mistaken perception that nerve to mylohyoid is V3. It's not the case. V3, the mandibular division of the trigeminal nerve, that nerve to mylohyoid is a branch of it. Really, it's a branch of a branch, if you will. Okay? So nerve to mylohyoid specifically, its derivation is the mandibular nerve, V3. I don't know that I've got a picture, but in laboratory, you can see this on many models. When you're looking for nerve to mylohyoid, what you're looking for, it's going to be one of the only places where you're going to see a nerve lying on the muscle. So you'll see a nerve lying right here on mylohyoid, but then if you follow it, what does it do? It goes deep to the anterior digastric muscle because it innervates both of those muscles. All right? So you're looking for a nerve right on this inferior surface, if you will, because it's really below, going right across here and then deep to the anterior digastric. That would be nerve to mylohyoid. Remember, and I got a great question about this, about, we talked about how these muscles can act in different ways. And I talked about the origin insertions change or whatever. It's still the same muscle. Something like mylohyoid, it can either depress or pull down the mandible, or it can be involved with elevation of the hyoid bone. So some muscles can act to move either of these two bones. It's the two muscle attachments switch. It can be an origin or insertion, depending upon, do you want to move the hyoid or do you want to move the mandible? The muscles back here, stylohyoid, we talked about, it has a function of pulling up and retracting. That means back. Protraction is forward, retraction is back. So it can act to elevate and retract the hyoid bone. Posterior digastric kind of aid in that or whatever. So remember, facial nerve for these two, and these would be V3 nerve to mylohyoid for these two. That's why these are typically more involved with depressing the mandible. These are more involved with elevation of the hyoid bone. Okay. Remember that the two digastric muscles, they have a common tendon between the two, and then they have this structure here, it's called a fascial sling, that kind of, let's say, tethers or ties down the tendon to the hyoid bone. So they don't really directly attach to the hyoid bone. Instead, they can act on moving the hyoid bone because of this little fascial sling. If you don't know what a sling is, think about your arm, you hurt your arm, put it in a sling. If that still doesn't help you, go to Google. Google sling, and maybe you'll understand. But there's the common tendon between the two, and this fascial structure ties it down to the hyoid bone. So when it contracts, it basically, the tendon pulls on that fascial sling, and that's what will actually move the hyoid bone. The tendon doesn't attach directly to it. Whereas if you look at stylohyoid, it goes down and it does attach directly to the hyoid bone. Remember, here are two muscles, the one that sits above, and so on the practical, there's not going to be a green arrow and a black arrow. There's going to be a pin or an arrow on one or the other. Look for which one's superior or above. Stylohyoid, the one below, inferior, will be posterior digastric. Mylohyoid, I want you to understand, it's a big, broad muscle all the way across. So some people say, oh, it's right here. I'll say, what about right here? No. Mylohyoid is all of it. There's another digastric anterior belly here, but all this muscle is mylohyoid, floor of the mouth. Make sure you know origins, insertions, actions, innervation for these muscles. We kind of talked about these. Okay. You do not have to know anything about geniohyoid at this point in the course. We'll talk about geniohyoid when we get to floor of the mouth later in the course. So basically, if I were to say something about geniohyoid, act like you never heard of it before. Don't waste any gray cells on that structure. Gone. Okay. Triangle that one, that's not a big deal. So we've mentioned how the muscular triangle is one that basically had the infrahyoid muscles in it. So superior belly, sternohyoid, sternothyroid, thyrohyoid. One thing about this, let me see what my next slide is real quick. These. Understand that the omohyoid and sternohyoid are kind of more superficially located. That sternothyroid, thyrohyoid are a little bit deeper located. This pattern is a little bit hard to see on most of the models. Trying to tell, I think you can see sternothyroid on some of the models. Some of the models, maybe one or two, you can kind of see thyrohyoid, but you don't really see this nice pattern like is shown on here. Typically what happens is there's a little median tendon, like a little raphe, if you will, where these two muscles insert. But I want you to think about this for a minute. These muscles, let's forget omohyoid for a minute. These three muscles right here, it's all about sternum, thyroid cartilage, hyoid bone. So here is the thyroid cartilage. So I've got a muscle that goes from sternum to thyroid cartilage, sternothyroid. It will lie deep to sternohyoid. It goes from the sternum all the way up to the hyoid bone. And then from the thyroid cartilage only, not below, thyroid cartilage up to the hyoid bone, I've got a little muscle called thyrohyoid, innervated by C1 only. Okay? So these two tend to be what we think of as being deep. These two are what we think about being superficial. These two should be easy to see. These are a little bit more difficult. Some of the models you can see sternothyroid pretty easily. This is the one that's a little bit more difficult to see. Thyroid gland down here in the neck. Some of the models you can see it very nicely, kind of this brown sitting down in the neck. But all you see is just brown thing sitting in the neck. There's the thyroid gland. Anything else I need to do relative to this picture? I don't think so. So again, viscera. That make sure you know that. Think about, so the thyroid gland would sit anterior to the trachea. Trachea sits anterior to the esophagus. You do not need to know anything about this inferior thyroid artery at this point in time. We'll get that next when we do root of the neck. We'll see where this actually comes from. And we'll actually see these two are the little transverse cervical, suprascapular, so we're going to see where all that stuff is coming from. But you can imagine, this artery, superior thyroid, gets the superior aspect of the thyroid, this artery will get the inferior aspect of the thyroid. Thyroid gets its blood supply from two big structures, so it's a pretty important gland, you can imagine. Don't worry anything at all about the parathyroid glands. So again, here is what we're trying to say for, here would be the trachea anteriorly, here would be the esophagus posteriorly, and it doesn't show as well as I wish it would, but there would be a groove right between those two that would be the tracheoesophageal groove. So there's a nerve on each side that loops around and travels within that groove. So these would be the recurrent laryngeal nerves in that groove. And many of these models, there's some great examples of this that you can see. Most of them are on the models that have like just that bony piece that forms the kind of C shape on the top, and there's almost nothing on the neck. It's just the posterior structures. You can see those two nerves very clearly on those models.
Dr. Spears?
Yes?
You said that one of the recurrent laryngeals is longer than the other.
So the question is going to be anything about the recurrent laryngeals, not where it loops around, which one's longer. Next exam, you're going to need to know that. This exam, all that I care that you know about recurrent laryngeals is they lie within the tracheoesophageal groove. Then we'll get kind of their pathway next exam, and then later on we're going to get what they actually are doing on it. So we're going to a little bit about the recurrence on a couple of exams coming up. Great question. Don't fill up any gray space with anything you don't. So there's trying to show you trachea, esophagus. There's the tracheoesophageal groove. So that nerve within the groove, recurrent laryngeal. Here's a little nerve and artery going through the thyroid highway. I said I wasn't going to say any more about that, didn't I? So here's a nerve not going through that membrane, going down to the, so there's external laryngeal nerve. So I think I've kind of hit this up. These little things tell you what's in the triangle, so kind of make sure you know, especially the major triangles, what's inside of there or whatever. But I will stop right there for neck. Any questions about neck? Foster, is that a yes?
Actually, I have a question. It's about the suprahyoid muscle innervation. I'm really clear on the nerve mylohyoid, and then I just wanted to confirm that this posterior belly, the digastric, and the stylohyoid are innervated by the facial nerve.
That's right.
And are those the two nerves that we need to know about for this?
You got it.
There's no more? Okay.
Two only
Thank you.
for now. That muscle said you don't have to worry about geniohyoid, it gets a different innervation. Any other questions about neck? Okay. Sit there for just a moment, or if you will, let me kind of look through something real quick.